Michael Pallanti. I'm the practice director for Radiology Affiliates Imaging Practice. I started out as an X-ray and CT tech. I got into teaching from there. Then I moved on. I became the director of the radiology program for Penn Medicine. And that's what really led me towards RP in my current role as practice director for physician services. In early February, I fractured my fifth metatarsal. About 5-6 days after the fracture, I'm in the kitchen at the sink, I'm just washing my hands, and all of a sudden, I get this feeling where it's like, oh my God, I can't breathe. And the next thing I remember after that was I was laying on the floor and my wife was standing over me screaming, dialing 911.
His lips started turning blue. I realized, oh my God, he's not breathing. So I grabbed, Michael's a big guy, so I don't know where I got my strength, but I grabbed him, I pulled him up to try and get some airway into him. And as I did that, he sort of came to, and I was able to grab my cell phone, call 911. The ambulance took Michael, I followed. And as soon as he was okay, I grabbed his cell phone, and the first thing I said was, I gotta call, your guys, I gotta call, and Mike said to me, call Dr. Feldstein.
The first call that I got was from David Feldstein, my colleague. He had gotten a call from Mike's wife. Then that's what sparked debate between myself and Dr. Feldstein as to what could possibly have caused it, knowing that he had a fracture of his foot recently. What I saw was basically what I would consider, without having any clinical information, a massive PE. He has a huge saddle emboli with basically occlusion of upper and lower lobe pulmonary arteries on the left and near occlusive on the right. Significant right heart strain shown by that dilated right ventricle. And he also had a markedly dilated main pulmonary artery measuring about 3.7 centimeters. At that point, I'd seen it and I'd spoken to the intensivist, so I was already on my way to the hospital. Before I got to the hospital, I spoke to Dr. Feldstein, and we just decided to go in together and evaluate. And that's when we had a discussion as to what we were going to do, thrombectomy versus thrombolysis. And our decision for thrombolysis instead of thrombectomy was because of the significant clot burden. We figured he was pretty delicate at that point because he couldn't really lay supine for any extended period of time without gasping for air, requiring oxygen. So our concern is if we start messing around with thrombectomy, we could throw him over the edge and then we'd be chasing our tail at that point. So since he was relatively stable at our end, we decided we were just going to do thrombolysis. So we went in, we did our pulmonary angiogram, but you rarely see no perfusion to that left side whatsoever. You see minimal perfusion to the lower lobe pulmonary vessels on the right, and even less in the upper lobes. So, you can kind of see faint filling defect in that right main, which, consistent with the saddle embolus that we were seeing. So everything that we were seeing on the CTA kind of played out with the pulmonary angiogram. So we basically just left 2 thrombolysis catheters, one on the right, one on the left. We preloaded each infusion catheter with 6 milligrams of TPA, and then ran TPA overnight at 1 milligram per hour per catheter with a total of 500 units of heparin through the sheaths. And that's kind of where we left it. I called Dr. Newman, who was my colleague who'd be there in the morning, to let him know what we'd done and what we had seen so he could follow up appropriately in the morning.
I went in to see Michael that morning to just assess and see how he's feeling, and he said he was feeling better already, but still experiencing some chest pressure. I said we bring him down later on during the day and kind of see where he is as far as the angiogram, and then make a decision about what next steps we would take. He came back in the afternoon. This is the right side, and you can see he has improved perfusion. He has some decreased perfusion up in the right mid-lung zone, but I was more interested in this lower lobe, left lower lobe area, where there was lack of perfusion. So rather than have him continue with 2 catheters, I elected to switch out the catheters and just place one on the left side in an effort to try and get better perfusion to his left lower lobe. And he stayed with the lysis catheter overnight until the next morning, when I handed off the case to my colleagues who took it from there.
So I came in to see Mike the following day after 2 days of thrombolysis to determine if we had to proceed with another day of the procedure. So I saw Mike. His shortness of breath was better, but it was still present. And he did tell me that the pressure on his chest was significantly worse or not getting any better. So at that point, we decided to bring him to the cath lab to do another procedure. I happened to be at St. Mary's Hospital with my colleague, Dr. Thalani, who's also an interventional radiologist. So given the fact that we do these procedures, we both do them, we said we might as well work together as a team. It'll be quicker for Mike. So we start off by taking images. The images on this screen show a very large clot burden within the distal main right pulmonary artery. You can see this very large filling defect. So after seeing this clot burden, going along with his symptoms of chest pain and pressure, and he's still working to breathe, we decided that we have to now do thrombectomy. So the images on this screen show the first shot after we removed the large blood clot from his lungs. As I'm running through these images, you can now see that the upper and truncus right pulmonary arteries are now widely open, where in this image, there's a large blood clot here, and you can't even see these vessels. Here you can see that they're patent and they're open. He's getting great blood flow to his lungs. So then we turned our attention to the left side, the left main pulmonary arteries. The images on this screen are from the first angiography that we did on the left side. It's difficult to see. There's some breathing motion artifacts, but there's large filling defects within the left main pulmonary artery and multiple lobar branches of the left pulmonary artery. And then the images on this screen are images post-thrombectomy. So as we run through them, you can see that these filling defects, which were present pre-thrombectomy, are now completely gone. Again, the clot burden was massive, and this is what we took out after 2 days of thrombolysis. So you can see he has great blood flow through the left side of his lungs. We were happy with the result. We decided to stop the procedure and then let him recover. He left the hospital, 3 days later. The pure emotion you see when you see, his wife is upset and nervous, it makes you really think that what we do really truly helps people when, again, it's in your own backyard.
By them dropping everything, getting to me as quickly as they did, they really did save my life.
These doctors are wonderful. This isn't a job. They're miracle workers.